And we're back. The gang is all here. Dr. Hussein, Dr. Waziski-Kuhn, and myself, the co-founders.
EM board bombs.
Of EM
Let's
board
go.
bombs. Hey, you want to hear an interesting stat? Greater than 10,000 followers on Spotify now.
Let's go. But you know, the funny thing is, it's 10,000 followers, but
that's pretty crazy.
We get like way more listens. So how about more people actually click the follow button on Spotify that listen to us? So we can get credit for the hundreds of thousands.
It'll cost you nothing.
Streams that we get. Hey, this is the first time all three of us have been together for it's been more than like a year or two. It's been a while. Yeah, I think
was
so.
Was it the C. diff episode?
Yeah. It's been a while.
Oh my gosh,
As the young, ones would say, it's been a minute.
Rain boots. And we're talking about diarrhea again.
What is up with us always, joining together for GI episodes, right?
Yeah, that's messed up.
I think it's beautiful.
Hey, EM board bombs, you know who we are.
We tell you what you need to know. Hey, you got a 52-year-old male presenting with 2 days of left lower quadrant pain. Now, he's been, quote, biohacking his gut on GLP-1.
Let's go.
And he hasn't eaten fiber since 2018. He proudly reports a carnivore diet to, quote, fight inflammation. Ooh. His temperature on arrival to the ED is 100.6. His heart rate's 95. And he has mild left lower quadrant tenderness to palpation and no rebound guarding or tenderness. He has no medical history. You get a CT, abdomen, pelvis with contrast, and it shows uncomplicated sigmoid diverticulitis. So what are your next steps here? What is the correct answer? Choice A, admit for IV antibiotics. Choice B, start oral antibiotics and discharge. Choice C, no antibiotics, outpatient supportive management. Choice D, emergent surgery.
Hey, before we do that,
who am I going to pick on?
What do we go into? EM rapid bombs. EM Rapid Bombs, more than 500 episodes there. That's our premium podcast, 3 to 5 minute long episodes. Pretty awesome. We have so many people, actually tons of residencies have signed up. If you think your residency would be interested to get your program director, reach out to us. But you can find it on emboardbombs.com. Go to the question bank. Again, only podcast that's doing Q&A style rapid questions. Increase your ITE score, your board score. EM rapid bombs. Hey, who's going to answer this controversial? It's not controversial. Let's be real. This is not controversial, but
it shouldn't be.
It's going to get heat. It's going to take heat. What's the answer here?
Yeah, the correct answer here is C. That was no antibiotics. No antibiotics. Just no antibiotics. Just outpatient supportive management.
There are people across the country admitting people for IV antibiotics, and they're like, whoa. They're like, maybe we could have believed just outpatient management with oral antibiotics, but you're saying no antibiotics? I know. Look, we brought the receipts, though. We brought the receipts. This is not anything new, right? Isn't that what the kids say these days, Briggs? It's bringing receipts. I don't know. I mean, you guys are younger than me. I'm the only one here with graying hair.
Oh my God! You're gonna pull that
hair. I'm the only one. But
always do this, Mr. Associate Professor.
Brought the receipts. Hey, so the American Gastroenterological Association recommends that antibiotic treatment can be used selectively rather than routinely in immunocompetent patients with mild, uncomplicated diverticulitis, and this is with low risk features present, right? We mentioned this patient had no significant past medical history. Obviously, this person was immunocompetent, right? So this patient meets criteria for conservative management without antibiotics. He's immunocompetent, has uncomplicated disease on CT, lacks severe signs of systemic infection or sepsis, and has no mentioned comorbidities. To add on to this, we could have added labs for this patient that basically showed that he had no white count elevation, CRP was fine as well. So we'll give that to you as well, right? You might be like, well, what did the lab show? The labs were fine in this patient, right?
That white count of 15, though, let's be honest.
Yeah, it is.
Pretty arbitrary.
But we're going based off of guidelines here, right? Yeah.
What number you want to use? I'm going to see him sitting in a meeting at the AGA annual meeting. They're like, what do you want to use, 12? No, 18? A little too high. How about 15? That's
so
a good
we're going to
number.
get some pushback here on that low grade fever, right? That temperature 100.4. People are like, wait, that's like straight up sepsis and everything like that. Yeah, you guys want to get into this? Who wants to take this one?
I mean, it's a low grade fever by itself does not mandate antibiotic therapy. And I mean, think about that with anything else, any other disease that you're treating. Are you really going to give antibiotics to someone that has, I don't know, like some sinus pain because they have a temperature of 100.4? Like, think about what you're doing here. Is that like the one deciding factor to give someone therapy? No, this patient is immunocompetent. He has no other comorbidities. He has mild abdominal pain. He can be managed with observation and supportive care. The fever is not persistent. It's not accompanied by other high risk features.
And so then if you really want to dive into guidelines and have things back you up in the studies, really high fever as defined as 101.5 was a cut point used in some of these guidelines and studies that basically showed, hey, for those folks, go ahead and do antibiotic therapy on them. But again, this is like a very mild, it's a temperature of 100.6. It is not a high fever. So we're going to get into the weeds of this. I know, because it's blowing people's minds. Like literally people are listening to this podcast, and I guarantee like 80% of the people listening to this are like, well, hold on a minute. Like I'm getting really nervous, not, sending someone home without antibiotics for uncomplicated diverticulitis with low risk features. Hey, before we get into the nitty gritty of when antibiotics are recommended and kind of further differentiating that, can we talk about why the other options were wrong?
Yeah, let me handle this. So, choice A was talking about IV antibiotics and admission. So admission is only for complicated cases. Now that's in general like an abscess that's present, and this is an abscess usually greater than 3 centimeters. Any free air, of course, in the abdomen, pneumoperitoneum, you're calling surgery. And patients that have uncontrolled pain, maybe they can't ambulate at all, they're significantly elderly with comorbidities, like they're immunosuppressed, of course, chronic kidney disease, other severe metabolic issues. These are all issues that you would admit, like, regardless for. These are things that the patient would come in, you're like, okay, you're staying because you have low potassium anyway, from vomiting or diarrhea. These are all separate issues, and that's really what you're admitting for because of the addition of the infection. Choice B was talking about oral antibiotics for everyone. This is an old practice, and it's really funny because Marlene and I have talked about this elsewhere offline, and we're like, this is going to be one of those things we talk about like 20 years from now, and we're like, do you remember when we used to do this? Because eventually it is going to be the standard practice. It is standard practice, but it's just not picked up in a lot of places. We were joking about it, and it's going to be so funny to tell younger trainees and students like, we used to give Cipro and Flagyl when I was in medical school for this, and then it was Augmentin, Moxicillin, Clavulanic. Sorry, we're not sponsored by Augmentin. And
we're open to it.
We're open to it, though. Not for this, though.
Right.
And but now it's considering antibiotics only for significant systemic symptoms or immunocompromised status. So it's not just, hey, the CT reads diverticulitis, doesn't matter how the patient is. They could be texting on their phone with like no abdominal pain. You don't just give them antibiotics. And then choice D was fairly wrong for many reasons. Emergency surgery, which that is only reserved for literally a perfed abdomen, right? Peritonitis, pneumoperitoneum. That's really the only case on the board.
We're not just reflexively nuking their guts anymore with just, ciprofloxacin bombs, Yeah.
Right.
And causing C. diff.
I know that.
See prior episode.
I'm picturing me in, 50 years when I finally go gray, and when I'm a senior, senior attending, and some junior resident's going to be like, whoa, diverticulitis, like what did that used to be like? And I'll be like, they used to give antibiotics to everyone. They're going to be like, so did like everyone just have C. diff or something?
Did they? Basically.
Yeah.
Basically.
Hey, we don't really get into pathophys that much, Briggs. So can you give us 5 lines of pathophys or less?
I like how he hands it off to me. Yeah, so I hate pathophys stuff. So diverticula are essentially these like little false outpouchings, and they're in the colon. They go through the muscular layer, and they're most commonly in the sigmoid colon. And essentially this leads to them filling with some bacteria, transmigration, whatever. and it causes inflammation. And it can cause this thing called diverticulitis. So remember that patients can have diverticulosis. That's a chronic thing they have their whole life, basically. And then diverticulitis is the infection. Uncomplicated means just these micro perforations. I know it sounds scary, but essentially it's localized inflammation. It goes away with time. Complicated would mean really scary things. So an abscess, a fistula, bowel obstruction, perforation, a real perforation, like air literally in the peritoneum. And the symptoms most commonly is going to be this abstract, I feel like it's abstract most of the time, lower abdominal pressure, sometimes radiates to the back. Honestly, I feel like it's on the differential as like the kidney stone patients, except it's not as sudden
it's
onset.
Not colicky.
And it's usually the bowel movement changes with it. Usually bowel movement changes. And they can't have a fever. They can't have nausea and vomiting. It's usually a change in bowel habits of some type. But greater than 70% of the time, it's left lower quadrant pain. Right-sided pain, if they mention it, it's because they could be younger people or classically Asian patients. So why don't you, Marlena, go over the new guidelines for uncomplicated diverticulitis?
Yeah,
outpatient management.
New to some, but actually have been present for a number of years. So the outpatient management.
So, I'm going to set you up even more here, Marlena. There were updates, we're talking about like what years, it's like 2014, 2015, where the AGA basically was like, hold up, maybe we need to like rethink this whole like antibiotics being mainstay therapy for all diverticulitis, right? So they kind of put a pause on that. At that time, the evidence was kind of like, maybe there. But then there were multiple studies that got released over the course of the next few years. And then in 2021, is when, the AGA and multiple medical specialties and Cochrane reviews showed that we should not be giving, antibiotics just to everyone with diverticulitis. And we really need to put our thinking caps on and determine who needs it, who doesn't, right? And one, it starts off with uncomplicated, patients. So uncomplicated diverticulitis, rather, with low risk features. Get into the weeds of that, Marlena.
Remember, saying uncomplicated and low risk should not be followed by antibiotics. But when are antibiotics indicated? So the AGA's identified some specific high risk features that are going to warrant antibiotic treatment in uncomplicated diverticulitis. So remember, this is uncomplicated, but with high risk features. So those are patient factors. So if you have an immunocompromised patient, if they're frail, significant comorbidities, so like diabetes, CKD, if they're a cancer patient being treated for cancer right now, if they're on methotrexate for their RA, things like that. Then you consider their clinical features. Do they have refractory symptoms? Are they just having uncontrolled diarrhea? Are they vomiting a bunch? Have their symptoms lasted for, greater than 5 days before presentation? Are they totally miserable? Then you've got your laboratory markers. We mentioned these earlier. So you can check a CRP greater than 140 milligrams per liter or a white blood cell count greater than 15. We talked before about CRP not being a super useful test that nobody really gets anymore. So when might this actually be useful? You can get a CRP if that's greater than 140 milligrams per liter or a white blood cell count greater than 15. Either of those would be indicative of a need for antibiotics. So if the white blood cell count is like on the edge or, 14.9 or 15.1, you can get a CRP to push you in one direction or the other. And then imaging findings, we did mention you should probably image these patients. They can have a vague presentation unless it's somebody with a history of this is my diverticulitis. This is what it's always like. And they have a long history of getting lots of CTs for their diverticulitis. Get a CT. There used to be a practice of giving these patients oral contrast. You don't need to do that anymore.
Please don't do that.
Just wanted to mention that because that is another dated practice that I do see commonly. But if you get a CT and you see a fluid collection or if there's a longer segment of inflammation on the CT, that's associated with a higher risk.
And you mentioned all these things, and I know people listening to this are thinking in their brains like, you really want me to go through this stuff? Can I just give this patient ciprofloxacin? And yes, just pause. This is one of those things. It's like a clinical practice update that's been around for years. And you should take pause and try to determine, is this uncomplicated, with low risk features, or are there high risk features present? But continue, Marlena.
Yeah. I mean, you're a doctor. You can use your brain. I believe in you.
If you want to get even more into the weeds, like what does it mean, significant comorbidities, right? Like what does that mean? That can be kind of vague sometimes. And Marlena mentioned a couple of those, but in the context of diverticulitis management, really that's referring to chronic medical conditions that are going to impair the immune function. So this is going to be some obvious things like poorly controlled diabetes, CKD, heart failure, cirrhosis, things like that. So if they have significant comorbidities or they're very frail, that's not like your ideal patient, right? Like that super frail ESRD patient with terrible diabetes. That's not one that you're like, maybe I shouldn't give antibiotics on these folks, right? No, it's kind of full stop. That one's pretty obvious, right? So, again, those conditions warrant antibiotic therapy, even in uncomplicated diverticulitis, because they can increase the risk of progression to complicated disease. Hey, EM Board Bomb listeners, we have gone way over on this episode of time. We pride ourselves on having episodes that are 15 to 20 minutes long, and this one continues to go over. So we're going to break this up into a digestible format. This is part 1, and we're completing it here. Next up, we're going to start talking about some of the treatment algorithms and also some of the things that you can tell your patients on discharge. This has really become a big episode because diverticulitis, especially uncomplicated diverticulitis, when it comes to antibiotic usage, has really changed in the last few years. Yet we don't see a lot of practice change, but it has a chance to really change and impact the way we treat patients and improve the way they're treated, and treating them in a evidence-based, guideline-based manner. So we'll come back with part 2 next week. Thank you.